Hey, there you are.
Do you hear me, Frank?
I can hear you. Join audio.
Can you hear me okay, Frank?
Yep. Perfect.
Jeffrey?
Okay. Looks like Andy's having a little problem joining, but other than that, hold on. Okay, guess we'll start. There's a couple people, looks like they're having some issues joining, but we'll start. Okay, so good afternoon, everyone. The only two questions or issues that people had this week were discussing the viral filters and what we should be doing. I checked, we still have, I think Angel said Angel's on, but I think he said we have 48 of them left at headquarters. So I'm gonna email the lieutenants and see what the stock is on the stations, but Angel has orders in for about 1,500 to different vendors, 3 different vendors, but they're all, you know, back ordered and there's no ship date. So we'll have to discuss what we're gonna do if we run out of viral filters. And then the other question would be this, you know, pediatric inflammatory syndrome that's going on in some of the pediatric patients. So I guess I'll turn it over to Jeff and Adrian to discuss the viral filters and the pediatric inflammatory thing.
Sure. So the viral filters, obviously, we should prioritize those for BVMs, right? So in cardiac arrest, if you're using a BVM, you want a viral filter on it. You can use it on the CPAP, although I'm not sure. I've been seeing various stuff online. I'm not sure exactly how effective it is at decreasing viral particle transmission with CPAP. There's not a lot of data on that. But if you have it, use it. The highest risk would be BVM during a code. So if we only have a few of them, we may want to prioritize them for those, for the BVM, and for the vents, obviously on the RMC side, if you're transporting someone with a vent.
Those are separate. Those are separate viral filters for the vents, and for some reason they don't work on the bag valve masks. I don't know something about the connection. So I mean, I'll see if there's a way of jerry rigging them. But I think for the vents we're in good shape. It's the bag valve masks.
And we're somewhat limited on those for the bag valve mask, right?
Right. So I think we put 10 in every station or 15 in every station. And then we have that sub stock here at headquarters. So I think we had a total of, 150 to start with. So,
Right.
but we're going to continue obviously trying to get them.
All right, good. And then the pediatric stuff. So I'm just going to share my screen for a second, Frank.
Okay.
Oh, you have to let me, apparently.
Okay.
Stop sharing.
I'll stop sharing mine. I stopped sharing mine. So is it better?
Yep. All
Okay.
right. So just so people are aware of what information is being put out there, these slides, can everyone see this? These are the slides from the governor's briefing this morning.
Can you maximize it?
So across here,
Can you maximize it? It's small.
I can make it bigger, but it gets blurry. How's that?
Okay. No, that's fine. That's better. Yep.
So currently in New York State, there's about 100 cases that DOH is looking into that they think are this COVID-related illness in children. It's similar to Kawasaki's, which we can talk about again in a few minutes, or toxic shock syndrome. The difference there, Kawasaki's is more of a post-viral, or we think viral-mediated inflammatory process, and toxic shock is due to a bacterial infection, but they have a lot of similarities. There's been 3 deaths in New York with this, a 5-year-old, a 7-year-old, and an 18-year-old. This is interesting. This is the age distribution of these 100 cases that we're seeing in New York. And if you look, it's predominantly in the 5 to 14-year-old range. Really very little of it under a year old. And then once you get to, 19, 20, 21, we're really not seeing much of it. So it's really in that kind of school-age child age that we're seeing most of these cases. And again, there's only 100 cases, so it's hard to know, exactly what to make of it, but that's what we've seen so far. So this is what the governor told people they should seek immediate care for. So if your child has prolonged fever, more than 5 days, difficulty feeding for infants or too sick to drink, severe abdominal pain, diarrhea, or vomiting, skin changes, so that would include rash, so pale, patchy blue, trouble breathing, racing heart or chest pain, decreased amount or frequency of urine, or lethargy. So these are all, fairly common things that you would pretty much tell most parents about pediatric patients that they should be evaluated for this. The problem is none of this is really diagnostic for this entity because it's a lot of non-specific stuff. I will say that in the cases that are out there, what we've been seeing more of, and even in other states that have seen some of this now, the chest pain is more common than the trouble breathing. It's not really presenting with a lot of trouble breathing like COVID itself is in a lot of people. It's more chest pain. And because what we can talk about Kawasaki's, but one of the inflammatory things that happens with Kawasaki's is, aneurysms and inflammation of the coronary arteries and the pericardium and the heart itself. So that may explain some of their chest pain. So DOH is advising all hospitals to prioritize COVID testing for children with these symptoms. And we've been given that instruction also. And we do have an in-house 1-hour test, rapid test. We're limited in the number we have. So we do run them for certain things like people who need to go to the OR. So we will do this test for kids also. So if we have kids where we're entertaining this diagnosis at all, we will do a rapid in-house COVID test, which we get the results in an hour. What's interesting is that what we're seeing with these patients is that 80% of them tested positive for COVID and 20% only tested positive for antibodies. So this is not, it's not just in the acute COVID phase that they can have this problem. We're seeing it sometimes several weeks later as a post-infectious type of inflammatory syndrome. So they don't have to actively have COVID. They could be recovering from COVID and then develop these symptoms after that. So that's kind of the basics. I'll stop sharing my screen now. But that's kind of the basics of what's out there and what the governor has been telling people every day in his press briefing. So you may see an increased number in pediatric calls. Obviously, parents are going to get very concerned with this, and they may call a little more frequently with these types of non-specific symptoms, which may just be a viral syndrome. I would anticipate that you may see increased calls from the pediatrician's office and the urgent cares, because I think a lot of people now are going to think every patient they see has this and start wanting transport. As far as capabilities, I'll speak to NIAC. we do not have the capability to treat this entity. If someone actually has this, they need to be in a pediatric specialty hospital. Some of the lab testing that's done for this, and certainly some of the treatments, which may be high-dose aspirin or IVIG, they need to be in a monitored pediatric ICU type setting where they have the availability of pediatric cardiology and to get pediatric echoes and those kind of things. So, if you have a kid who just looks sick, and you're more than welcome to bring them here. If we think this is what's going on after the workup, or we have a high level of suspicion for this, we may transfer them. Doesn't mean that it was wrong to start here. If you have a kid where this is a diagnosis, for whatever reason they were diagnosed already, I would go directly to a pediatric. I'm not sure how Adrian feels about that, but probably similar.
Yeah, definitely. Everything that Jeff said, we're mirroring here at Good Sam. And yeah, I agree. The sickest kids typically should be going to pediatric centers as well. So no difference in treatment on this side either.
And then obviously the other thing is we still have a lot more questions about this entity than we have answers. It's relatively new. There's a lot of studies going, a lot of investigation at like Columbia and CHOP and a lot of the big pediatric centers around the country. So I'd imagine in the coming weeks we'll learn more. But right now that's kind of what we know about it. So I don't know, Frank, if you want to go through your slides or.
I don't know if he wanted to show, again, this is Kawasaki, but I guess it's similar symptoms.
Yeah, so Kawasaki, it is similar to Kawasaki. What we see with Kawasaki is fever, usually for 5 days or more, although you can have incomplete Kawasaki, so we would call that in someone who had fever for 3 days, not 5. But generally, it's 5 days of fever or more. You see, just like this picture, a conjunctivitis type picture, a rash. They'll often have swollen lymph nodes. And you may see exactly the oral changes, kind of cracked skin, lips, and tongue that's kind of like a strawberry tongue. You see the rash there. The other name for Kawasaki's is mucocutaneous lymph node syndrome. That's kind of a more descriptive term, right? So mucous membranes, skin, lymph nodes get enlarged. And again, the problem with this is that, not the syndrome itself, a lot of that supportive care and they'll get better. It's the sequelae from it. So kids with Kawasaki can develop coronary artery aneurysms. They actually can have MIs as a result of it. So that's why it's so important that it's treated aggressively. And the treatment for Kawasaki's is aspirin and IVIG, intravenous immunoglobulin, to treat it. So that's kind of what they're doing with these kids, plus minus sometimes the aspirin, sometimes not. I saw just yesterday, Columbia has a treatment protocol, which is mostly kind of just expert opinion. There's nothing really definitive. So
Jeff, we should be working these kids up ALS then.
I would. A kid who has this is going to be sick. They're going to look sick. They're probably going to be fairly dehydrated. They'll be febrile, tachycardic. So I would say, if they look ill, probably you may have difficulties getting lines and stuff, and that's fine. But you would, and again, you may have a kid who has a history of febrile seizure or something that could precipitate that as well. So you're not going to see a lot of these. So
do you want us to hold off on aspirin?
Yeah, I wouldn't give them aspirin.
It's a weight-specific dose anyway, so.
Yeah.
I think from the pre-hospital setting, you want to most focus on, their oxygen saturation if they're having difficulty breathing, and their hydration status if they look very dry or dehydrated. I think that's probably, just the recognition of the possibility that this could be what it is, and treating, the most pressing issues in the pre-hospital setting is respiratory and circulation,
Yeah.
And as far as treatment goes, I wouldn't be giving a kid aspirin, because in general, you don't want to give a kid aspirin anyways, but you're not treating it like a 68-year-old with chest pain, but you're supporting the child and transporting them to where they could do further testing.
So should we be doing a 12 lead on them?
I don't, in a pre-hospital setting.
Yeah, kid's got chest pain.
Yeah, you could do it, but again, it's not. they're really not going to be cath lab kind, because you can see this picture that's on there right now. That's an coronary aneurysm. It's not really, occlusive. It looks the same, but it's not the same physiology as adults who get occluded coronary arteries. So the treatment it's still different than, go in and put a stent in.
There's certainly no harm in doing an EKG, but at the same time, I don't think it's going to change the management, certainly in the pre-hospital setting. Just getting the kids to a hospital quickly and supporting them from a respiratory standpoint and circulatory standpoint is probably the most pressing issue. But listen, if you have time and the patient's otherwise stable and they're having chest pain, there's no harm in doing an EKG, especially kids in older age groups too. A 21-year-old could, have different pathology. They could have been using cocaine or some kind of other drug. So you have other things that come in with an older kid that you might not have with a 5-year-old.
I'm just asking because if we're going to be doing that on pediatrics, we're going to have to add more pediatric electrodes.
Yeah, I would say it's not a priority.
Okay,
yeah,
thank you.
I agree.
If it's like a teenage kid and you can use adult electrodes and you have the time, sure, it's great. But on a young kid, really not important.
Is there any sort of like dysrhythmia that you see more commonly in this type of situation, or is it pretty much, just mostly tachycardic syndromes?
It's usually tachycardic.
Yeah. Unexplained tachycardia is like the hallmark of myocarditis. So it's the same kind of thing. Now, again, they'll probably be febrile. So you'd expect some degree of tachycardia, but you may have like tachycardia at a proportion to the fever or persistent, but you tend not to see a lot of other arrhythmias, like VTACs and stuff like that, because it's not a sick heart to begin with.
Okay, does anybody have any other questions on this? I believe there were 2 cases or 3 cases in KJ like a week ago or whenever we first discussed it, because I had gotten some texting emails from the Hatzola up there.
Right. And those went directly to Columbia, or?
What do you think?
Yeah, I think so.
Probably Sinai.
Right.
No, I think Sinai. No, I think they go to Columbia. I think Sinai is good.
I think
As
KJ
New
goes
Square.
to Columbia.
Yeah. So.
Frank, we had
Yes.
one yesterday that we transported from Good Sam, and I think the kid was from Haverstraw.
Mhm.
Heart rate was about 180, 185, and had fever
How
for a
old
couple
were
of days. 7 months old.
7-month-old. Yeah, he was a 7-month-old. I know about the case. I haven't followed up with anyone over there at Westchester, but I do know about the case and I intend to follow up. So maybe the next time I can give you guys follow up. Did you have a specific question about the case, or you were looking for follow up?
That we had encountered it here in Rockland County because Frank had brought up with KJ, and that it was consistent with everything you guys were saying, the rash around the mouth and the high tachycardia and looking for that, but there wasn't much to do other than some fluid and support until we got him to Westchester for their PICU.
Yeah, I'm aware of the case. I'll follow up and give you guys some information. It was a Hispanic kid, correct?
Correct.
Yeah. I'm looking at the chart right now. I'm bringing it up.
I have a question. Is the syndrome contagious at all, or?
No. So the syndrome itself is an inflammatory syndrome, right? If they have it at the same time that they have active COVID, the COVID can be contagious. But if it's post, recovery and, they're antibody positive but test negative and have the syndrome itself is not contagious. The problem is you're really not going to know early on. So you should treat them as if they have active COVID, but it's the COVID that's contagious, not this syndrome.
Okay, thanks.
Yeah.
Okay, does anybody have any other questions on this? Okay, does anybody have any questions on anything?
While they're thinking about it, just one comment on antibody testing.
Okay.
So because DOH has been doing a lot of it, and they're here at NIAC this week, and they've tested most of the Montefiore system employees now, and several other, FDNY, NYPD. And what they're seeing is actually the rate in healthcare workers on the downstate is actually lower than the general population. It's about, it was about 10%, where the general population was like 12.2%. So, and then NYPD was like 10%. Fidney was higher. Fidney was 17%.
Wow.
But it shows that, you know, the PPE works. And, you know, the healthcare, what we're seeing is that healthcare workers are not getting sick at a higher rate than the general population. And those, which means maybe those healthcare workers are getting it as part of the general population and not necessarily at work. But it's encouraging the antibody results that from what the state's doing, that it seems like, you know, the risk is not as great as we may have thought it was initially, assuming you're doing, you know, proper PPE, donning and doffing and hand hygiene and all that.
Okay. So does anybody have anything?
Does antibodies mean immunity?
No, we don't know that.
Actually, can you hear me?
Yeah, it doesn't, the fact if you're antibody positive, we don't know if that offers any immunity to you. We don't know how long antibodies may stay around. So yeah, it probably would give a person a little peace of mind, knowing that they had it and now they have antibodies. But beyond that, you really can't say, well, I had it, so I don't need to wear my PPE, or I had it, and now I can go on vacation because I'm good. We don't know how long, if any, immunity you get from having antibodies.
Right. I mean, even the quantitative titer test, we don't know what number means protected. So.
Yeah.
Is there any information on if there's multiple strains of the COVID floating around or anything?
So there are multiple strains, 2 main strains, but from what I understand, and Jeff, correct me if you've heard otherwise, that both of the strains are relatively similar from a biology perspective, but they have, you know, they reference an Asian strain and a European strain. I've read stuff that the European strain has more significant disease associated with it, but structurally, as far as I know, they're fairly similar. And this particular virus doesn't mutate at a high rate so far, as compared to a virus like influenza, where it mutates a lot.
Right. And it seems, and what the research are doing with the vaccines is that regardless of the strain, they have the same spike protein, which they use to attach to the lung cells to enter. So that's kind of been the target of the vaccine, is this spike protein.
I'm waiting until this is almost done. Not rushing over there for COVID.
All right, so Donna's in a hurry. Who else has a question?
Anybody else with anything?
Can anyone hear me?
Yeah.
Yeah.
Along the lines of antibody testing, just an FYI, if anybody's interested, I went to the van behind Refua on Route 45, just outside of New Square, and I was in and out of there. Oh, sorry?
That sounds shady already. Go ahead.
But I was in and out of there in 10 minutes when I went in around 5:30 p.m., just in case anybody's interested in going before work.
And is that quantitative or qualitative?
My understanding it's quantitative.
Okay. Anybody have anything? Jeff, Adrian, anything else?
No, good on this end.
Okay.
Yeah, I mean, everyone's clear on all the protocol changes and everything. We're back to kind of where we were. Everyone's good with that. You know, the regular collaborative protocols in effect.
I have a quick question back to the antibody testing. My understanding was that the FDA left it as a yes/no, not actually having the providers release the numbers. Is that changed, or is that?
So there's two types. There's two types. There's qualitative and quantitative. So some of the ones that were doing qualitative testing, like Quest, they in the background they were doing quantitative and getting numbers. They can release them. Some of them approved, and Mount Sinai's test is approved too, because they got it approved as part of the convalescent plasma protocol that they're doing. So yeah, and I think Refua's program is through Mount Sinai apparently, so it's a quantitative test.
Got it. Thank you.
Good, David.
Jeff,
Do we know?
Hold on. David
Jeff,
Brewer just said that Rafua's program is quantitative through Mount Sinai.
You've got Lucas on, right?
Yeah, Frank, I went on Friday and I got my results yesterday.
Whoops. Hold on.
Oh, I think you just muted yourself.
Yeah, I just muted him.
Most likely got robbed.
I'm sorry. I went on Friday to get tested there, and yesterday they called me up and they gave me a number.
Okay.
So
I can't figure out who's.
Yeah,
That's
so it's
Donna.
quantitative, but
Or
again,
whoever her partner is.
obviously the higher the number, the more antibodies. But we're not sure yet what those numbers mean. And as far as immunity goes, we just don't have an answer on that. Likely, you have some protection, right? Just like with the seasonal influenza. I mean, even Fauci says this, that probably you have some protection, but there's no definitive immunity that we could say. Like, I wouldn't give up your N95 because you have antibodies.
I don't know. I can't figure out who's got the background noise. Okay. Anything else from the audience? Ray, are you on? Do you have anything? I think he's on. He is on. Yeah,
He's there.
let me unmute him. Ray?
There you go.
Ray?
Yeah, you hear me?
Yep, we hear you now.
Okay, I have a couple of things I just wanted to go over. First of all, thanks a lot to Jeff and Adrian for doing these medical control CMEs. They're really very helpful and keep us all up to date on everything. This is administrative stuff, Jeff. So Jeff and Adrian, if you have to leave, I'm okay with that. The first item I have is the summer shirts that we were talking about putting out. We have them in. We're going to be rolling them out over the next couple of weeks. They're blue shirts, polo type shirts, golf shirts. We're going to give them a try this summer, see how they work out, see if people like them, if they hold up like regular cotton shirts. I know there's been a lot of people asking for it. I've been resistant to it. So I guess with age, you mellow out a little bit. So we're going to give it a try this summer and see how it works out. The second item I have is that we posted a position for a captain, RMC captain. Paul Estep vacated that position. He's no longer in it. So we're looking for people to submit resumes for that position. Nelson posted it. We're going to be holding interviews probably next week. We want to get